and welcome to another episode of Health Check right here on Hope TV, where you look and live. It's me, Kerry Kagiri. Maybe you can't tell. It's still me. But we have to be in studio as we do have a great conversation going on. Today's disease that we'll be talking about is one that requires you to act very, very fast. And fast in this case is an acronym. We'll be telling you much more about it. In studio with me today are two gentlemen. Yay! Welcome. Welcome to Health Check.
Thank you very much.
Yes, it's really good to see each and every one of you. We do have an occupational therapist. Please tell us what exactly you do and your name, please.
My name is Duncan Chengo. I am an occupational therapist by profession. I am the founder of the Ability Therapy Place, which is basically a neurorehabilitation center for people who are struggling with neurological issues. When you talk about occupational therapy, it is synonymous to disability management. Because whenever an occupational therapist is being mentioned, there has to be a challenge or sort of a limitation in performance. Yeah, when I talk of performance, I'm referring to how you do things away from normal, from normal human beings. Occupational therapist's main objective is to allow people engage in very important chores, despite them having an existing sort of a disability. The chores I'm talking about is what we refer to activities of daily living. This include matters of every human being feeds. Every human being goes to the toilet, every human being does grooming, and then every other human being dressing up. Then other than that, we have what we call instrumental ADLs that include the likes of writing, typing, mobility, etc., etc.
Wow.
Yes.
And in collaboration with this are two careers that come hand in hand. And with us is Dr. Kinoti himself. How are you, sir?
I'm very well.
Good evening and welcome. Thank you for joining us. I know you've had a really long day and thank you so much for extending the grace to come through. But you are a neurologist. What does this feature for those who are hearing this word for the very first time maybe?
Thank you very much, Kerry, for having me here this evening. It's a pleasure to be here to talk about the disease of stroke and other matters pertaining to the nervous system. And my name is Dr. Kinoti Ndege, as I've already said, and I practice in Nairobi. I'm currently the head of Department of Medicine at the Kenyatta Hospital, but I also consult in various other hospitals in the city. Now, a neurologist deals with the diseases of the nervous system. And the nervous system involves the brain, the spinal cord, and all the nerves. And that's a system which basically helps you to perceive what is happening outside your body and to react to that stimulus. So without the nervous system, basically you would be in a vegetative state. You'd be like a cabbage, because it's a system which helps you to understand what's happening and to make movement and other responses to whatever stimulus that comes your way. So I deal with the diseases of the brain, diseases like stroke, things like epilepsy and various other conditions like that. Diseases of the spinal cord, things that cause paralysis, both of the upper and lower limbs, as well as diseases of the peripheral nerves, people who may have numbness or tingling or pain and other things in their limbs. So it's a whole extensive discipline with lots of conditions. And I'm really glad that we are going to pick apart one of them today.
Yes.
And discuss about stroke.
The stroke we're talking about, as we were having a conversation, it's a circulatory...
It's a circulatory disorder.
Disorder, that's the word I was looking for.
Yes, yeah. Basically, the brain requires constant circulation of blood for it to function properly. So if anything happens to interrupt that circulation, then the brain will not function. So it is a disease of the brain, but it's a disease of the circulation of blood within the brain. So the circulation of blood falls still under the circulatory system.
That's true. We'll be having much more on that. We cannot start this show without having the conversation that's making us have to be in masks as we start today's episode, which is the coronavirus, COVID-19. You've all had different interactions. You're at the Kenyatta Hospital. I'm sure you'll be giving us a very in-depth report on also what people need to know about the disease. But for you, how has this affected the practice? How has this affected you in this season? And what would you tell Kenyans right now?
It's quite a sad situation that the country is crying. You know, traditionally we are used to, when we cry here, we call other people to come and help us. You know, some support. Unfortunately, this time is every man for himself. It's been sort of a challenge, especially, you know, we deal with patients every day, and some of our contacts sometimes it's very difficult to keep distance as a professional based on what I do. But it's been quite sort of a challenge. Dressed in full gear every other time, very important. Thank God for masks. Washing hands, which is matter of tradition, we have to perfect it, and every other time. Yeah, it's been quite sort of a challenge. Just to mention that people who are currently living with disabilities, it is very important for them to know that they are part of the population. Unfortunately, they are likely to be more at risk here because of some of the pre-existing challenges that they live together with. So my call to those people is to join the rest of the country. And I would also pledge with the government not to forget that there are people who require a little bit some sort of an extra mile. It has come at a time when now we have to consider and we have to budget for everyone. If you're marking sink for everybody to wash hands, please make sure you have sinks which are low enough for people to wash hands, for those people who are in wheelchair. Whenever you are making mask, it's always very important to know that there are people who don't have you know, ears good enough to tie their you know, etc.
Wow.
Yeah.
So let's also consider those with disability. Let us encourage them, and even just explaining to the children, the older ones who cannot understand what is happening, because life is not business as usual. Thank you so much, Dr. Kinoti.
Yes, please.
Your experience with coronavirus, you have come, I'm sure you've come head to head with it as you're trying to pack as you get to your office.
Yes.
Yeah.
It's a new situation that we have found ourselves in. And a few months back, of course, no one would have foreseen how things have evolved so far. Here we are in the studio talking about stroke, but we have to be in protective gear because basically it's something which is not visible. It's an invisible enemy that has come, and we have had to change our behavior in all different ways to cope. So it's a fluid situation. Every day we learn new things about it, and every day we learn new ways of coping with it. But it has changed the practice of medicine a lot. You know, our practice, just like Mr. Chengo has said, is an intimate kind of discipline. We are not able to be far from the patient. You need to be close to people, talk to them, listen to them, understand them, show empathy, show understanding. And that requires you to be quite close. In fact, the other day somebody was talking how it's difficult to reassure people. You meet frightened people, you are meant to smile at them and show them a nice, understanding facial expression, but you cannot because you're in a mask.
So already you've created a boundary.
Already there's an emotional barrier which the mask brings about. And not just the mask, but all the matters of distance. But of course we understand it's something we must do. If everyone follows the guidelines which have been put across, use of masks, hand washing, social distance that has been talked about. If you don't have a lot of business to do in town or other places, stick to your home, isolate yourself if you feel that you're not in the right shape, present yourself for testing in health facilities, follow the directions of people if you have to be in quarantine. No one is putting you there, you know, as a prisoner. It's that we have a disease that we have to fight with, and therefore everyone has to understand and cope with it. and try to see how we are going to get out of this. But this kind of thing, an epidemic doesn't last forever.
It's true.
And this kind of coronavirus, this SARS coronavirus 2, is a variation of a common cold virus.
Yes.
It's something which has become a bit more virulent than other viruses.
Yes.
So it will follow the general pattern of this kind of thing. It's very different from, say, something like HIV, which once infected remains with you forever.
Yeah.
So it's just a matter of time. If we just push ourselves and go over it, I can see within the next 6 months this probably is going to be history. Once we are past the peak.
Yes.
So I would urge everyone to push themselves, try to persevere with things, and within the next few months, once we are past the peak, life will go back, probably not back to normal completely.
Yeah.
But at least things will be a bit more bearable than they are right now.
Wow, thank you so much for that, Hope. You are on Hope TV, where you look and live. This is Health Check with me, Kerry Kagiri. Remember, we are live on Facebook. What you can do is go to your Facebook page and share the link. Our numbers are right below the screen. You can send in your questions live in studio to our neurologist or to our occupational therapist in studio. We'd like to introduce our case study for today's episode as we talk about stroke. Here it is.
Stroke is the leading cause of death and severe long-term disability worldwide, and it occurs when part of your brain is deprived of oxygen, causing the brain to die. It's a non-communicable disease that has taken its toll on Kenyans with little or no realization.
My name is Edward Deligondo Konzolo. I'm 53 years old, married with one wife and 4 children. I was a teacher. I'm still a teacher, but I was told to go home until when I will be well, is when I can come back to work.
Edward was teaching in one of the secondary schools here in Nairobi, and according to him, his lifestyle was a big contributor to the stroke condition he now has.
I was teaching at a Light Academy secondary school at Karen when I was caught up with this disease. Given that it was a high-cost school, so everything was provided: transport, lunch, and anything you can think of. Mine, I was told to teach and teach only. I used never to go with students outside to play and so on, because there was a teacher in charge of games. So for us, we were told, you come in, teach, and go. And we were being picked by a vehicle in the morning. And when it comes afternoon at 3, we are dropped back with that particular vehicle. So I ended up putting on much weight because food was provided. So I put on a lot of weight, and I used never to check on my pressure, sugars, and so on.
People at risk for stroke include those who have high blood pressure, high cholesterol, and diabetes. For Edward, the symptoms developed one Sunday morning on his way back home from church.
I went to church, praised with the other people and so on, and started walking back home at 8. Now, that is the time I felt something might be going wrong, because I could feel some dizziness, and trying even to say I'm feeling dizziness, it was a bit difficult. So I just decided to continue going with my friends. I was with the 2 friends of mine. So when I was just 50 meters away from my house, I was seeing it somehow 50 meters, is when I fell down. Now falling down, my friend now asked, what is happening? They came and uplifted me. Trying to answer them, it was a bit difficult.
And that was Edward's beginning of a long journey with stroke, from symptoms and diagnosis to treatment and management.
Thank you so much, Edward Consuelo, for sharing that story. We have our neurologist in studio and our occupational therapist. We'll start with you, Dr. Kinoti. You have seen that case study just relating to that. Can you explain clearly to our viewer what stroke is?
Thank you very much, Kerry, again. Now, stroke is a disease of the brain. But as we mentioned earlier, it's a disease of the circulation of blood within the brain. It's something which occurs suddenly when a blockage, the most common of stroke causes a blockage within one of the blood vessels in the brain. And that means that a part of the brain is deprived of oxygen. And the cells in that region of the brain that's affected stop functioning. Now, the brain is what controls everything in your body. So every movement you make in your body, every feeling you have in your body, even emotions, all the thoughts you have, everything is in the brain. Really, the brain is you, your personality, your desires, your movements, everything you do is in the brain. So when a part of the brain stops functioning, it means that whatever movement, whatever function that part of the brain had is going to be affected. So stroke can literally cause almost anything, depending on the part of the brain it affects.
Wow.
So if it affects a part of the brain that controls movement, it will lead to loss of movement on the part of the body that's affected. There are also parts of the brain which control for coordination and balance. So you might have normal power in your limbs, but you cannot coordinate very well. You will find that you try to touch something and your hands are shaking, you can't reach there. Speech as well is something controlled by in your brain. So you might find that your speech is lost. Both the output of speech, where you are unable to speak, to express what you want to say, and even the understanding of speech. People talk to you, and you look like you're understanding, but you have not understood a thing that you're being told. You cannot comprehend at all. So it does cause so many things, including even feelings, where you lose some types of feeling in some parts of your body and so on. So the effects of stroke can be particularly devastating. And it's important that people get sensitized about stroke and learn how they can protect themselves and prevent themselves from getting to this situation.
For now, he has shared his story, and we wanted to highlight the friends took him home, not knowing. What are some of the signs when we see someone? What are the, as we said, there's an acronym for it, FAST as well. You can break that down just as we get into that. And then we'll come to occupational therapists who will tell us, even going with the case study, but more so, what are these aspects of life that you have witnessed being affected? So,
yes, now, if a person is having a stroke near you, sometimes it's the people who are around who may notice it even before the person knows they have a stroke. Many strokes are not painful. Many of them do not even cause a headache. The person tries to, like he says, he was trying, like Mr. Edward says, he was trying to lift a cup of water or tea, and it poured all over him, and that's when he realized that his arm could not function. So people need to be sensitized and need to be aware, so that if someone in your vicinity gets any element of facial weakness, you find that the mouth is moving to one side and they are not as symmetrical as they usually are, you need to be aware that they could be getting a stroke. Arm weakness, you find that they're trying to do something, you give them a pen and they can't try it. They try to remove something from their pocket and you find the hand is not cooperating with them. So arm weakness. Speech. Speech, there can be slurring of speech, difficulty with articulating various words. There can also be difficulty with naming things. A person wants you to give them something and they say, give me this, but they cannot know that this thing is called a pen. So they can lose the naming ability, even naming of people and naming of various things. So speech can be affected in many different ways. So those are the easiest things for a person to notice: face, arm, and speech. So the acronym FAST stands for face, arm, speech, and then time is of the essence. So T is for time. So if that happens, note the time that it has happened, because when you get to hospital, you will be asked, what time did this thing happen? How many minutes have passed since they started? Because the medication that is usually used is dependent on time.
Time, okay.
So the doctors will want to know how much time has passed since that happened. So the acronym FAST is a very useful one for everyone out there to know and keep it in mind every time. Especially those who live with people. I know we shall talk about the risk factors for stroke.
For sure.
But if you live with people, elderly parents and other people who may be at risk of stroke, it's very, very important that you have this in mind every time. And when that happens, you take them to hospital straight away.
Wow. Occupational therapist, you've seen just how his movement is, his motion. In the picture that we see him sharing earlier, he seemed to be, you know, everything straight, but his hand, what are some of the things that you have seen your patients being affected by?
Thanks. I think on this case study, it's quite sad. There were all signs that something was wrong.
Yes.
Unfortunately, I think there is a lot of lack of information about stroke, because in my opinion, it is something that perhaps could, if all the precautions were taken, it couldn't have gotten to that point.
Yes.
Yeah, so I want to go back to your questions about what is affected.
Yes.
Stroke, as Dr. has said, can affect different parts. When you get affected on the right side of the brain, then you're likely to get paralysis of the opposite side, and the vice versa is also true.
Oh, okay.
So this means that when you get paralysis of the right side, this stroke comes with several challenges. Number one on the knee is loss of speech. Number two is loss of cognitive function. So when I talk of cognitive functions, I mean memory, perception, orientation to time, person, place, concentration issues, emotional issues, attention span, etc., etc. Then, of course, the other thing is whenever you get affected on the right side, and statistics are that majority of the people in the world, they are right-hand dominant. So what stroke does is it takes away the part of you that earns you livelihood. In other words, your work technically is gone, because we work using our hands.
Yes.
Apart from few like you who work
Uses
a
their
lot
mouth.
using their mouth. So, of course, at some point you talk a lot, but you also end up
That's true.
also doing a little bit of some few chores in typing, in signing. And away from that, then the most challenged part of these things becomes what you call ADLS. And that abbreviation,
ADLS.
it's an abbreviation for activities of daily living. This includes some things like dressing. Traditionally, our dresses are designed to be, donned or to be put using two hands. And here you are, one of your side is completely weak. Then how do you dress? How do you, cook? How do you feed? How do you go to the toilet? And etc., etc. The other challenge mostly is challenge with mobility. Whenever you get a stroke, the aftermaths of the stroke leaves you with some reasonable level of disability. And these disabilities can be disability 360 degrees. You can either barely get a challenge in mental functioning cognitively, whereby you can no longer say just 1 + 1 = 2. Then the other problem becomes mobility, where you can no longer move, especially at the first stages. But of course, with rehabilitation, then you end up at least getting some reasonable.
And that's what you do.
And that is technically what I do every day. Yes.
Okay.
So we deal with different challenges differently.
Yeah.
Whenever someone gets a stroke, most of them land in ICU. So occupational therapists have a lot of duties to do, especially in critical care. When you're in critical care, you have less movements. Many times you are highly sedated. So at this particular point now, we need to preserve your function, that you don't lose your function. We do this using fabrication of orthotics and splints. We fit them in different, for example, if it's a hand affected, I need to position it in what we call a functional position. When you're out of critical care, of course, the first place who needs to know, would ask the questions, where are you going home? Where do you live? In Nairobi, all of us live in 5th floor and above, you know? So the responsibility of the occupational therapist here is to do a home-based assessment, of course, in preparation for discharge, because we need to know, when you go home, how big is your door? Can a wheelchair get inside? When you get inside, do you have stairs inside your house? When you want to go to the toilet, would you access, is your toilet wide enough to get inside using a wheelchair? When you want to take a shower, is the shower wide enough? Does the shower has places where you can grab and support yourself if you want to? Then of course, manyumba nimebomoa nyingi sana in Nairobi in doing this in my... Like
my recommendation is we need real, no more Chinese doors, just proper 83 inches.
Yes. So other than that now, the challenges of hand, for example, if you get a stroke of the right hand, there's something that we call dominant hand transfer, whereby I have to teach, literally train you again how to write, how to type again using your left hand. If the right hand has some reasonable level of function that I can retrain again. When I talk about retraining again, is as Dr. has said, it's all about the brain here. So the brain has got one key function that we say it's neuroplastic. So I assume that I can train the already existing functions of the brain to try and assume the role of the function that has been lost again.
Wow.
So I'll take you again through the process of trying to
write, hold a pen,
to strengthen again, because there is a lot of muscle weakness, to strengthen again and try to help you again. Now, once you recover, the only person who stands in the gap between you and your employer again is the occupational therapist.
We'll be coming back to that even as we continue, because this is the next level. We need to completely understand with you, Daktari, what are the symptoms that we see? Because we've talked about when we are going through fast, the stroke is already happening. Are there symptoms prior to that?
Thank you. Now, stroke is actually the reason it's named stroke is because it strikes you.
Wow.
It strikes you out of the blue. Wow. 1 minute you are completely fine, no problems. The next minute you get struck down. So there are no major warning symptoms. In fact, Mr. Edward, his case was a bit atypical because it evolved over time. So his was an evolving stroke. It began, and a few hours later it's still getting worse, getting worse, gradually. Most do not follow that pattern. Most start and suddenly you are completely weak on one side, and then from there now everything starts. So there are no major warning signs that one might talk about before the stroke actually strikes you. It strikes you, and that is a stroke.
Who is most likely to get this stroke?
Now, stroke, anybody can get a stroke because there are two ways that stroke comes. The majority of strokes are when there's obstruction or blockage of one of the vessels within the brain. But there's another minority type of stroke where there's rupture, where a blood vessel ruptures and the blood leaks within the brain and causes damage in there.
Wow.
Now that's a smaller subtype. The main one that everyone talks about is going to be the one where the clot goes and blocks something inside there. So you know your blood is made to clot. That's a way that prevents you from bleeding too much when you get cut, if you have an accident or something. So the blood, you can always form a clot at any time. So a stroke can affect children, can affect young people, can affect elderly people. However, there are those with things that are termed as risk factors. And the risk factors are very important to know because some of them can be modified. Then you know this person who has got this risk factor, if he handles this, he might improve and the risk will be less. And others are not modified. Now let's start with the modifiable ones. are things like hypertension.
Yes.
Hypertension is a major risk factor for stroke in our society. A lot of people have hypertension. But if managed well and the blood pressure kept at a reasonable level, it can prevent that person from getting cardiovascular disease, circulatory disease, including stroke. The next thing is diabetes. It's also another major risk factor for stroke, and lots of people have diabetes. You know, the lifestyle conditions have been recently, you know, everyone is talking about them, lifestyle diseases, because the lifestyle has changed. And right now, in fact, with the current lockdown because of coronavirus, a lot of people are at home.
That's true.
They are eating, they are gaining weight, they are not exercising.
Yes.
So maybe the next thing we shall be seeing next year is an increase in strokes because of the current inactivity that is happening due to this thing.
Wow.
So even when people are at home, they need to avoid being sedentary. As Mr. Edward talked, he said he was in a school where his job was just to go and teach,
Eat,
and eat food,
get dropped,
and go home.
repeat.
Exactly. So his lifestyle was sedentary, and that's also a major risk factor for these things which can be modified.
Yeah.
Then there are other types of risk factors, but now you can talk about the non-modifiable ones. But let's not forget cholesterol. A lot of people also have cholesterol. So really, it's a terminology, it's a thing for all the lifestyle diseases. Hypertension, obesity, sedentary lifestyle, high cholesterol, diabetes. So those 5 things are key things to remember. Then the non-modifiable things are things like age. As you get older, you have got higher chances of getting a stroke.
Yeah.
So it's a disease of everyone, but more of the older people in society. Gender, in some ages, men are more likely to get strokes than women. Then there's also some discussion about ethnicity. In some areas, people of African origin, like in the Western world, are more likely to get stroke compared to people of other origins. So those are the risk factors. So if we understand the risk factors, then we can try to see how we can modify or improve those risk factors and prevent people from getting strokes.
Yeah.
So managing the ones which can be modified, people who have got hypertension need to take their medication well, reduce excessive intake of salt, because salt is a major risk factor for hypertension.
Wow.
Exercise more, manage people with sugar, need to manage their sugar.
Yeah.
And then diet, people need to have generally a healthy diet, lots of fruits and vegetables, and then finally exercise.
That's true. We're going to watch Edward's diagnosis clip. This is very important for us even as we continue to talk about the stroke, but I need to wrap this up with a question. Is stroke hereditary in any way or form?
Yes, one of the risk factors that are not mentioned is family history of stroke.
Family history of stroke.
So it's not a directly hereditary disease. The way, for example, we may talk about something like sickle cell, which you know that this is the gene which causes this. But if your family members have had stroke, you are at a higher risk. It doesn't mean that you will definitely have a stroke.
Okay.
But you are at your risk for it is slightly increased compared to a person who doesn't have any history of stroke in their family.
This is a conversation we are having with two great men in studio. We have Duncan Chengo, who's an occupational therapist, and Dr. Kinoti Ndege, who's a neurologist. The conversation is on stroke. And as he said, it just strikes you. You have to act fast. Check the face, check the arms, check the speech, and time. Time when you get to the doctor, then they'll be able to be telling us much more about new technology that is in the country to ensure that you can have your lifestyle, did you call it lifestyle?
Yeah.
Yes, your lifestyle back. This is the case study. One more time, the diagnosis clip.
After Edward fell out of dizziness, his friends who had accompanied him back home from church helped him to get to his house, but the stroke symptoms would only get worse when he got home.
Now, the tea was served on the table. So I picked it, using my right hand, I placed it here. Now, the next thing was, can you take now that tea to the mouth? Now, when I took my right hand there, I took it properly and got hold of the cup. Now to bring it up, kumbe energy had gone. Now when I pulled it, the cup had to fall. So when I stood very fast, kumbe the leg energy it has gone. So I ended up falling again. So it's when my friends there realized that no, there is something wrong. So they came again, lifted me up, and placed me on that chair.
His friends decided to take him to hospital, where it took him almost 24 hours before the doctors did the test and diagnosed him with stroke.
So the doctor told me, no, if I observe you, I don't see anything wrong with you. Kambia, I've had my hand has it lost weight, it lost some energy. My leg also, I fell down. Then he told me, fine, if that's the case, then we shall just admit you for 1 day. We do the observation, then you will go back. You see, what they took from me was just blood samples. They didn't go to an extent of taking my pressure, no. And they didn't also give me any drug. So I took my time. Now, after supper, now I was alone. So at that time is when the nurse was making a round. So when she came, she found my mouth had gone aside. I'm not talking. Like the eye, the what, I couldn't do anything. Of course, that is by around 8. Now they had to call that doctor because they had gone home. The doctor came back at around 9, coming to check, oh, what is wrong? Then he said, oh, this might be stroke. Then I slept up to the following day. When they did my head scan, that was at around 10, is when they discovered this stroke. I couldn't raise it up, but right now I can raise it up to that level. So
Edward is still going through treatment and management of stroke 7 years down the line, and he looks forward for full recovery. But would his story be different if he got timely diagnosis?
And that's the question we want to ask. Would his story be different if he got a timely diagnosis, Dr. Kinoti?
Most likely, yes, because in the case of Edward, looks like he didn't get his complete stroke immediately, but it happened gradually over time. So it depends on the kind of stroke he had. Because it's not clear if he had a blood clot or a bleed. If it was a bleed, most likely a vessel could have ruptured, and then it continued leaking blood into his brain as time went along, and that can actually cause worsening weakness over time.
Yes.
If it was a blood clot, it's possible that he was having several blood clots, which were continuously blocking the vessels as time went along.
Yeah.
Now, assuming that was the situation, if he had gotten some medicine to dissolve these blood clots at the very start, then probably they would not have evolved onto the situation that he found himself into.
Yes.
So if the diagnosis was made on time and if he was in a center which has the ability and the facilities to intervene quickly, probably his story would have been a little bit different from how it turned out.
7 years down the line, let me ask you, Chengo, do all stroke patients need to go through occupational therapy?
The answer is most probably yes. Because when stroke happens, as I've just told you, the aftermaths of a stroke may leave you with a challenge here or there. I've seen quite a number of very mild aspects of stroke, what we call a TIA, a transient ischemic attack, where the paralysis is not very major or very prominent. And some of these patients recover to full, almost completely full, with very few challenges here which are noticeable. But on the other side, based on how massive a stroke can be, then the answer is you definitely require some of these services to allow you to recover.
To recover. Our call line is now open. I'm sure you have so many questions. Send them in to 22232. That's our text line. Our call line is right below the screen. You can go ahead and grab it and call us live in studio. Our doctor and our occupational therapist will be willing to answer you. I have a question. What is this process of going through the stroke? How long, is there a specific time from the first symptoms that you see?
No, the stroke in most situations occurs quite rapidly.
Yeah, you said it's just...
It strikes you.
Uh-huh.
But now after that, you have to go through the diagnostic process.
The diagnostic process.
Because, you know, there are many things which can make you weak on one side. It's not only a stroke.
True.
You might have a tumor in your head. You might have a brain abscess. You might have an infection in the brain. You might have a seizure. After a seizure, sometimes people find themselves weak on one side. So there are lots of other things which can make a person weak on one side. And there are also more conditions which can cause weakness of the face alone. In fact, one of the commonest things which is mistaken for a stroke is a thing called a Bell's palsy, where you only have weakness of the face due to damage of one of the nerves which controls the face. And lots of people, I see lots of people who tell me that they had a stroke some years back. But when you look at it, you realize it was just a Bell's palsy, which is a very mild condition and not anything like stroke. So you have to go through a proper diagnostic process, and the diagnosis often is made by two ways: history and examination. If you come and tell me that suddenly you are fine, and then suddenly you got weakness of one side, you have all the classical signs: your speech went, your balance is gone, you have got weakness of your arm, your leg, and your face. If you present in that classical manner, and it was sudden and you're okay before, then clearly that will be a stroke. Then I will examine you. I will check and see what has happened. I will check your level of power in your limbs. I will check your speech. I will check your face. I will check your cognitive abilities and see just how well you are. Then after that, I will now tell you that it appears that you have had a stroke. Now from there, I will have to send you for imaging of your brain. You will need a scan to look at just what's happening to your brain. To confirm, is it due to the blood clot or is it due to the bleeding in the brain? So the final step is the imaging of the brain. You get the image and look at it, and you can tell the patient it appears that you got a blood clot and a vessel over here is blocked, and you can see this part of your brain is not working, and then from there now we can start. Now that occurs several hours after the stroke. If you come very early, the changes will not be visible on the scan. So I will have to make my diagnosis based on only the history and the examination. And that would be a very good thing. If the changes have not occurred on the brain scan, it means the brain is still viable. The cells have not yet died. So when you look at the scan, it looks entirely normal. Then in that situation, you'll be a good candidate for using these new treatments, which we can use to dissolve the clot or remove it physically. And hopefully, once we restore circulation to your brain, you will probably be able to get back some level of function again.
Well, I'd like to ask both of you this question. What do you do when you either realize you're getting a stroke, because someone might be alone, or you might be with people who do not understand? Maybe you watch this episode and now you know. What should one do? What's that first reaction? We can start with you, Daktari. Then we can come to you as you tell us how long does the occupational therapy also go on?
Now, there are no easy ways of self-treatment or home therapy for stroke. So if you find you're alone and you're getting a stroke, try anything you can to call for help. And if you're with someone who is getting a stroke, the best thing you can do for them is to take them to a hospital as quickly as possible. Time is of the essence. If you don't spend time at home trying to do first aid and other things, unless the patient has got something that they can't breathe, or you want to do CPR or some kind of resuscitation to them and you know how to do it, then you can try to save their life as you're taking them to hospital. Other than that, just take them to hospital as quickly as possible. And if you're alone, then try. You see, if you're alone and you get weak, you can't walk. In fact, I've had stories of people who tell me that, my mother was alone in her house and there was nobody nearby. And we found her the following day on the floor. She had slept there the whole night. She couldn't talk, so she couldn't call anyone. And she couldn't move to go to call someone. So maybe the best thing is if people have maybe a mobile phone which they can use with a normal hand and try to, you know, to call some emergency number somehow.
Or voice recognition. Oh wait, you can't talk even.
If you can't talk, it might be tough. But if you can talk, then you can you find a way of using your voice to activate, you know, to get some kind of help.
Yeah.
Yes.
Wow. How long, and do you have a response on the same question?
I think perhaps Dr. Ndege could a little bit put some light in this. If you've got an aspirin somewhere, yeah, I'm told it's a blood thinner, and it does a very good job. As you, of course, does not mean self-medication in the house. You do that. The first thing is just make a call or call for help.
Yes.
Then, if you are the one who you are near, it's about time. Everything, time, time. So get that person as soon as possible within the nearest facility.
How long does the process of occupational therapy go? I know cases are different, but you can just let us know in your experience.
From an experience point of view, again, it's a matter of how massive, how severe a stroke was. And again, when we talk about recovery, this is a little bit ambiguous question. As I told you again, the aftermaths of stroke leave someone with a disability.
Yeah.
So when you talk of recovery, we describe recovery as a process of try and go back to your chores, what you used to do every day, yeah, independently, because at the end of the day, that's all what my objective it's all about. This process can take from 3 to 6 years in between there, from my previous experiences, from 3 months to even 6 or 3 to 3 years, based on exactly how massive the stroke was. However, this is important to note from an experience point of view. Mobility comes first.
Yes. Mobility comes first.
Yes.
Let's pick your questions now live on our call line. Edward from Gong, good evening.
Good evening to you.
How are you, sir?
Fine.
Who is your question addressed to, and what is your question?
Dr. Ndege.
Yes.
Yes, the question is, there are times... Good evening to you.
Good evening, Edward.
Yeah. I wake up and find sometimes the leg is very heavy.
Yes.
I don't know how can I help that?
All right.
Yes, can you also please reduce the volume of your TV as you call us so that we can be able to hear you better? Thank you very much. Did you get the question?
Yes, I did.
Thank you so much. You can respond to it.
Yes, now, you know, the nerves are all over your body. You have nerves all over the place. So there are people who wake up with various nerve issues. You know, sometimes if you have slept in a particular position, even when you sit with your legs crossed, sometimes you can put pressure on the nerves around the knees, and you find the lower part of your leg has gone dead. It's numb. Sometimes if you sleep in a particular position, you can put pressure on some of the nerves in your hands, and you find that the hand is weak and numb. So I suspect what our caller was referring to could be that maybe he might have slept in a particular position where there was pressure on a nerve in the leg, and then he woke up with the leg numb and feeling like it's dead. But that is usually a sort of a minor problem. On exercising and moving the leg a little bit, that comes back. So that is not a stroke, and you should not worry that that is a stroke, unless you wake up with complete weakness of one side, and or fairly, weakness of one entire side, and you have some risk factors, which doesn't improve. But if it's just a nerve compression, once you wake up and do a bit of exercise, that usually improves. So you can distinguish between the two by seeing how quickly the thing goes away.
Okay. Our call line, our text line is open for you to ask any questions. The conversation today is on stroke. We have our neurologist in studio, Dr. Kinoti Ndege, and occupational therapist Duncan Chengo. A question to both of you one more time. Is occupational therapy the only therapy that is needed post stroke?
The answer is it is not.
Okay.
We have other variety of therapies that people who get stroke, they need to undergo. They are mostly members of the rehabilitation discipline.
Yes.
And other than occupational therapists, we have physiotherapists who take care mostly of your mobility issues and strengthening of your muscles. We have speech therapists who are also very key in an eventuality whereby you have challenges that are associated with speech. Other than that, also we have hydrotherapy, which is also at management of paralysis in water. Yeah, then it works very well because in water we say the level of gravity is minimized, and using the buoyancy forces of water, then you can also strengthen muscles. Psychologists are very important in this journey. Statistics has that majority of the people who survive stroke, they don't live past the third year.
Oh, no.
Because of issues about
Their psyche.
psyche,
Yeah.
yes, depression, mood issues. As I've just said, you know, stroke changes your status a little bit, and when you have been all health throughout life, and you have been up and about, you have been a father, you have been a mother, you have been doing, you know, everything. Suddenly now it comes and takes that aspect of you, which is very important. Some aspects of stroke, especially the ones on the right side that come with challenge with speech, they are very, very disappointing. You want to tell me, Duncan, can I have some kahawa? You just can't. You try and tell me, I don't understand. It's very, 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 very disappointing.
It is,
so
absolutely.
people end up sinking into depression.
Yeah.
Sometimes it becomes difficult also to understand. They tend to have mood issues. Is one of the complications of stroke. And when family members also don't really seem to understand how to deal with this person who just suddenly, you're likely to be considered as uncooperative.
And you'll tell us much more about, I would love to hear much more about that. How can we who live with people who have had a stroke, how can we encourage them? How can we work with them? How can we support them in many other ways? You'll tell us about that right now. The question that comes, just a highlight of what it is you've talked about, is which doctor exactly do you see? Like, I know this person is going through a stroke. Do I walk into the hospital and say, I want to see a neurologist? Do I go to the hospital and see a GP? What happens?
You know, stroke, when it's happening, an acute stroke, acute is when things are really happening there and then.
Yeah.
It's an emergency. So in that situation, you will not really, you know, like, for example, neurologists like me, I work in an office.
Yeah.
I don't work at the A&E. So if you come to my office, then I still have to send you to the A&E.
So that I go through
You go through the scanning and everything,
the
and
blood.
get stabilized.
Okay.
You know, the stroke, actually, there's one thing we didn't mention, is that it causes a spectrum of disease. From sudden death, is one of the causes of sudden death. If you get a very massive problem and your whole brain is messed up, then it can cause sudden death.
Let's hold that thought. Can we pick a call? Do not lose the train of thought. We're going. Okay. Hello, Kangede in Nanyuki. Good evening.
Good evening.
How are you, sir?
I'm fine, thank you.
Go ahead and ask your question. Who is it addressed to?
Yeah?
Go ahead and ask your question, sir.
Yes, my question is, I have been suffering from, have been seeing a neurologist. That is, I have one hand that shakes. Of late, one leg is being left behind when I walk. And I've also noticed that my speech is almost uncoordinated. When I go to hospital, I'm told that I have this disease that was with Muhammad Ali. What do you call it?
Parkinson's.
Parkinson. Yeah, I'm told it's Parkinson. And I'm told that it has got no medicine.
How old are you, sir? If you don't mind sharing.
Yes, I don't. Now I'm 62.
Wow. Okay.
So I wonder. I have been on medication, and I'm wondering if I'll ever get well.
Wow.
Because day in, day out, I'm getting a complication which seems like it cannot be treated.
Okay, thank you very much, Kangeda, for your question.
Yes.
Yes, indeed. The symptoms you have described in terms of your arms shaking, your speech getting a bit difficult to comprehend and a bit low. The symptoms you have described are in keeping with a group of diseases called movement disorders. And the Parkinson's is one of the commoner movement disorders. So it is highly likely that he has Parkinson's disease as has been diagnosed.
Yeah.
Now, Parkinson's disease and various other movement disorders are a group which technically can be called neurodegenerative conditions.
Yeah.
Now, what that means is that the cells of the nervous system degenerate as time progresses. So unfortunately, Mr. Kangede, it's not really, with the technology we have right now, we cannot reverse Parkinson's disease and completely cure it. However, it is manageable with medication, with exercise, with physiotherapy, even with occupational therapy as need be. It's manageable, and many people with Parkinson's disease are able to live their lives fairly comfortably with a few symptoms. So it's a long-term condition, unfortunately. You will manage it for quite some years to come. But if you follow, you take your medication and be reviewed as necessary, hopefully it will not cause too much deterioration in your level of, in the quality of your life.
Yeah. I'd like you to chime in on that. What can you advise Mr. Kangede?
Mr. Kangede, condition is, as Dr. Dega has described it, a group of movement disorders. And the only thing you can do about it is to manage it. And here, physiotherapy would help, which is about movement. So it's always advisable to seek an opinion of a physiotherapist and how to go about. And most importantly, other than now the exercise aspect of it, it is very important for Mr. Kangede to understand that it can only be worse if he deteriorates to a level where he is entirely dependent on people or relatives for very, very basic fundamental things.
That's true. So he's doing very well.
For example, for dressing, feeding himself, going to the toilet, writing and signing of things. So he needs to see an occupational therapist and get sort of a prescription of what we call activities. Activities, they are things that you do to try and enhance the already existing movement so that you don't lose them completely. Yeah.
When we come back, we'll be continuing with this conversation. But Mr. Kangede, I don't know, I just really feel the Lord is able to heal you and restore you fully from the top of your head to the sole of your feet. And so do not be discouraged by the motion. I kind of felt that discouragement, and I pray for you on this day that you will be restored fully. Jehovah Rapha is actually a healer, and he can heal you completely. I really believe in that. Right about now, however, we're going to this segment where we'll be showing you first aid. And as we get to that, other than, do you think we have enough occupational therapists in Kenya?
The answer is yes and no. For the longest period of time in Kenya, we have only had one institution that has been training occupational therapists. This is the Kenya Medical Training College. And KMTC trained for entire of Africa for many years.
Wow.
Until recently, when now some few universities, the Presbyterian University of East Africa and KU, they began training this program. On the other side, then some parts of Africa still don't train, so they rely on help from Africa, or from Kenya, sorry. Recently, there has been a very massive exit of occupational therapy practitioners from Kenya to the Arab Emirates. So there are fewer there. The biggest challenge is the fewer there now. The status of the country, because we are still fighting what we call basic diseases, etc. So there are quite a number who are jobless outside there. Yeah.
Okay. Can you let us know, Daktari, of facilities and places that people can go to for stroke? Very specific. Are there?
Now, most of our hospitals are able to handle stroke.
Okay.
Most of our good hospitals. We don't have specific stroke centers as yet. That is something which probably is going to is coming in the pipeline. But you know, now everything has gone haywire because of the new challenge which has come with this coronavirus. So all the resources, everything, and actually that's a challenge which is going to come, because we run the risk of neglecting other diseases for the next few months as we are focusing on this one, but that's something which we must do anyway. So we don't have specific stroke centers per se, but stroke can be managed. It's not something very complex. It can be managed by, in general, in most of the hospitals around here, as long as there are facilities like CT scan and physicians, even general physicians and other doctors. Stroke can be managed. It's something which everyone is taught in medical school. So most strokes don't even need a specialist. It's actually a very, very, very simple condition to diagnose and very, very simple to treat. The only problem with it is the duration it takes to treat a person. It's a long-lasting, causes long-lasting disability. So for the time being, we'll have to make do with managing our stroke patients in all our general hospitals. And so far, they have done a fairly good job because it's not a very complicated thing to diagnose.
Absolutely.
Allow me to just put some little bit of some light in what Dr. Dagi has just said.
Sure.
In the whole country, we only have 1 or 2 specific neuro rehabilitation institutions which are purely made for rehab. And one of them is the Kenya Spinal Cord Injury, which is mostly for spine, but we don't seem to have a stroke rehabilitation institute. I'm happy to perhaps share this. I left Nairobi Hospital a year ago, and this is what I left to go and do. So I'm currently put up a facility within Nairobi for stroke rehabilitation, to be very, very specific.
Wow, that's great.
Where systems work, like where you trained in the UK, people don't leave hospital for home. You leave hospital and you go into a neuro rehabilitation center whereby you are taught some few things. Just before I opened the neuro rehabilitation facility for stroke, I realized the demand. So home rehabilitation is very key. So I try and set up some few rehabilitation centers in different suburbs in Nairobi. I have around 14 mobile clinics in different parts of Nairobi, just because of the demand.
Wow.
Yeah.
That's great. And you guys can collaborate now, at least. You're welcome.
Yeah. Absolutely.
Even as we talk about this, let's go through some text and then we'll go on a quick break. Someone says, hello, I've been having lower back pain which extends to my legs, burning sensation on the legs. Could that be an issue?
Well, it's a nerve disease, but it's not a stroke.
Okay.
Probably a nerve is getting pinched somewhere in the lower back. So that one can be managed fairly easily. You just need to present themselves for treatment.
Tafadhali, present yourself for treatment. One person who has something that I suffered from a long time, and I think it's actually God who healed me, it's having the night legs muscle pulled. You're just sleeping, you're in the middle of a nice dream, maybe with a unicorn, and then, pain. What is that?
Some people do get cramps at night for various reasons. There's even one particular condition called restless leg syndrome.
Restless leg syndrome.
Yeah, where at night you find your legs are really uncomfortable and so on and so on. But then getting cramps at night can be due to various reasons, including over-exercising.
And health, not eating well.
Including inadequate calcium in your body. Including exercising without proper stretching and proper warm-up. So there are all kinds of different things which cause cramps. Most of them are harmless.
Okay.
Yeah.
Michael in Ruiru.
Okay, no problem.
How are you?
Hello.
Hello, Michael.
Hello.
Karibu sana kwenye show. Who would you like to ask a question to?
To the doctor.
Yes, go ahead.
Hello, doctor.
Hello, Michael. How are you?
Okay. Perhaps load your phone. Thank you very much. Our number is on the screen. 22232 is that text line. Daktari, there's a thought I told you to hold. Did you hold it?
Yes, I still have the thought.
Please.
Now, stroke, I was mentioning that has got a whole spectrum of presentation.
Yes.
When you talk of sudden death, it's one of the things which can give sudden death.
Wow.
Other than getting a massive heart attack, a stroke is another thing which can give sudden death.
Wow.
So it can range from sudden death to very minor symptoms that even the person will not even recognize that they have had a stroke. You just get a bit of numbness or weakness in your hand.
And it passes.
And it goes away after some time. So it ranges from a very massive, very major problem to something which might even be, some people may not even go to hospital with it because they'll just think it's something very minor. And there's also something which Mr. Chengo mentioned a bit earlier, the TIA, which is when you form a blood clot which blocks something in your brain, but it's only temporary, and then it dissolves again and circulation continues. So that it will not be a stroke because damage has not occurred in the brain.
Yeah.
It's just that you almost had a stroke.
Okay.
So that means that that person will have to present and get assessed so that now, because it means that a major stroke may be imminent. So you have to be assessed and risk factors found so that it can be prevented from progressing to stroke later on as you live.
Do our bodies have natural blood thinners?
Oh, yes. In fact, some of the medications, the way they work is by activating that system of natural blood thinners inside the body.
Okay.
Yes.
When we come back, more questions, more conversations on stroke. It is way broader than we ever thought. A circulatory, did you call it a disorder? I want to use the right word.
Yes.
Not disease, disorder.
Yeah.
Yes, and with the two people that you'll need the most when you're going through this, remember these two faces who have agreed to join us. That's Duncan Chengo and Dr. Kinoti. We'll be right back after the break. This is Health Check. It's on Hope TV, where you look and live. 22232. I'm coming back to all your texts.
In this segment, we are going to deal with choking, and choking specifically for an infant. That is something that usually occurs quite often and gets people very, very scared on how to deal with choking and a choking infant. Now, there are various things that will cause an infant to choke. Most commonly, while they're breastfeeding, they can have mild choking, which can be very scary. So what are some of the few things that we can do to assist this baby who is choking? So once you notice that the baby is choking, you will notice by they have a bit of difficulty in breathing and a lot of coughing. So when you notice that, then what you're going to do, you're going to try and turn the baby on as you support the head. You're going to turn the baby, support the head, and ensure that the head is lower than the rest of the body. So turn their head, support their head, and then using the heel of your hand, you're going to give them up to 5 back blows. So support, and then 1, 2, 3, 4, 5. Then check. You turn the baby onto the side as you keep supporting the head, and then check whether the obstruction has cleared. If it has come, if you're able to get a hold of it quickly, just pluck it out of or get it out of the mouth. But if the baby is still choking after the 5 back blows, what you're going to do, you're going to turn them onto their back. Make sure you support their head, keep supporting their head, and then using 2 fingers, you're going to locate the center of the chest and give them up to 5 chest thrusts. 1, 2, 3, 4, 5. And then turn the baby as you support the head and ensure that check whether the obstruction has cleared. If it has cleared, you can remove it from their mouth and place your baby in the recovery position. The recovery position for an infant is with their head lower than the rest of their body. And that is how you manage a choking baby. Now, if the baby is choking for a long time, you may need to call for help. Call for an ambulance and get them to a hospital as quick as possible, because remember, choking is a life-threatening condition.
Coronavirus COVID-19 is a respiratory virus spreading across the world. The infection is spread from droplets of coughing and sneezing of an infected person, touching or shaking hands, or being in contact with contaminated surfaces or objects with the virus. The signs and symptoms are fever, coughing, headache, body ache, difficulty in breathing. The disease can be prevented by regularly washing hands with soap and running water. Avoid close contact with people who have flu-like symptoms. Avoid handshake, hugs, and kissing. Also, protect yourself by covering your mouth or nose using a disposable tissue while coughing or sneezing. If you experience these symptoms and you had traveled or been in contact with a person from a country reporting COVID-19, you should isolate yourself for 14 days and seek immediate medical attention or report to the nearest health center. This message has been brought to you by the Government of Kenya and its partners. For accurate information on COVID-19, dial *719# or call 719. Follow us on Twitter at MOH_Kenya, at spokesperson GOK, at WHO.
Welcome and thank you for watching Health Check, where we bring you all kinds of experts on different fields. Today's conversation has been on stroke, even as we do have the effects of coronavirus. Let's thank you so much for watching. Those who are watching us live on our Facebook, Njeri Wamudhoni, thank you so much. She's saying she's loving the content today. And thank you for tuning in. Wanyaga Wanya, thank you. Just saying it's very enlightening. Frank Mola, good evening and thank you so much for watching as well. Corazon Aquino just letting us know that she is watching. We are still having this conversation. You can call us live with any questions you may have on stroke. 0708 756396. That's 0708 756396. Even as you ask the questions, if you just joined us, the one thing that we want to reiterate is fast. To be able to see how it is a person is responding. Has their face changed structure? Is that the right word? Yeah, help me. So has the face changed structure? The arms, also check the speech and check the time so that you can be able to give a proper report. And why we were talking about checking the time is because Dr. Kinoti says there's some really amazing medication that can help one, even as they get to seeing the occupational therapist, will be like, just go home.
Yes, indeed. This medicine, which is used to dissolve the clot, has been around for a while. Other countries with the health systems which are a bit ahead of where we are right now have been doing it for more than a decade now.
Wow.
So we are now in the process of trying to roll out across the major hospitals around the country. And it's really easy to do because it's just a medicine which is given through your vein and it goes in and dissolves the clot wherever it is in your head. So it requires a bit of training on how to use it and to be safe, because the fact that it dissolves clots means that it can cause a lot of bleeding in various parts of the body.
Okay.
So it requires a bit of training, but it's something which is fairly easy to do. The only thing is the organization of making sure that people arrive to hospital within 4 hours, so they're given this medication within 4.5 hours. So that is still of great difficulty. If you get a stroke now, you probably will be lucky because the roads are clear. You'll be able to get to hospital within a very short time.
That's true.
But during the peak of the times when you have traffic jams, getting from point A to point B, you find that you really are stuck there.
That's true.
Yes.
Doctor, can you pick a call from John in Kiambu? Good evening, John.
Good evening, Kerry and the doctors in the studio.
Yes.
Good evening.
Good evening.
Yes, I wanted to ask a question.
Yes.
2 days ago, my grandma was diagnosed with a mild stroke, and she was given medication. Yes, can you hear me?
Yes, she was given medication.
Yes, so now she's at home. Today I wanted you to just advise us to do's and don'ts, yeah, so that that stroke can be managed easily and faster. Yeah.
Okay.
Maybe or even on nutrition.
I hope you're getting the question.
do's and don'ts for a person who has been diagnosed with stroke. That's what he's asking about.
Who has been
Mild stroke.
Mild stroke.
mild stroke? Okay.
Yeah, mild stroke.
Thank you, John. Thank you, John. Even as you answer that question, will you get into, other than the treatment we've talked about, what is the traditional one that we have been doing? What do we have at hand? You'll talk about that, but answer that question first.
Yes. Now, thank you very much, John. Now, once stroke has occurred, your grandma is going to have a bit of deficit for a while. And there's this concept that Mr. Chengo talked about of neuroplasticity. Now, as people get older, their brains are less adaptive compared to people who are younger. So if you get a stroke, say, for example, you carry right there, I hope you don't.
I won't.
If you do, I think you are fairly young. So your chances of recovery are very, very good. Your brain is still adaptable, and you're able to improve in a very short time. If you get a stroke when you are elderly, your rate of recovery is a bit slow because your brain is not as adaptable as it would have been. So he needs to take good care of his grandmom, because such people have risk of falling down on the stairs and other places. And so basically getting around, that's one thing which is very important. But besides that, there's an element of preventing her from getting another one. Because once you get one, you can always get another stroke. The risks are still there. So she's got to use the medication, or the medication that she has been given, very closely. I see lots of people get a bit of improvement from stroke within 2 months or 3 months. Then they say, I'm fine, I've recovered. I don't want to keep taking this medicine anymore. There are too many medicines to keep taking every day. So I stopped taking them. Now, if you stop taking them, chances of you getting another stroke are pretty high. So make sure she takes her medication well. If she is diabetic, if she has hypertension, make sure those things are well controlled. So he's going to be measuring her blood pressure, her sugar levels very regularly. And basically talk to her, keep her in good spirits, make sure she doesn't get depressed, and then maintain her reviews with the various people who are seeing her. So if she's seeing some doctors, make sure she keeps on seeing the doctors. If she's going through a process of rehabilitation, make sure that also continues.
Yes, with that, you've also answered our question that stroke can actually reoccur. So be very careful. But Chengo, it would be important for you to chime in. How else can we support those in our various homes, emotionally, physically?
I think of most importance in a home setup is, number one, making life a little bit easy for them, using aids and equipment. For example, like our caller from Kiambu, it's important for the grandmother to have at least a walking aid that she can use to walk up and about. And then number two, the terrain of that home needs to be well balanced so that she cannot get accident falls, because she is already at a risk of getting a call. The other thing is family support systems, whereby it's important for the family to understand when the people who have acquired stroke, they have social issues, especially mood issues. You have to be very, very patient with them and try and accommodate them as much as possible. At the beginning of just before rehabilitation, they are likely to require total help. Like they could be probably on diapers. Others get something called incontinence, where they cannot control urine, or they cannot control for that matter. So it becomes important for family to be there for the sake of support. Yeah.
Okay. Carol from Kongudu Road had asked that she's having body shaking on her head and a couple of other symptoms like those. Daktari, you had an answer for Carol in Kongudu?
Yes. Now, those things of many neurological diseases actually require one to see, because there are many, many different ways that a person might shake. She might be having, say, a seizure. Some people with various types of epilepsy develop shaking of one arm or one part of their body if it's a partial seizure. She might be having a movement disorder. She might be having some kind of tremor. So it's really difficult to tell her that this is the diagnosis you have. But clearly she has got something that is affecting her. So I would urge her to present herself to a place where she can be assessed, and her diagnosis will definitely be made.
Okay. As I ask this next question, Dr. I want you to prepare for us some of the statistics, because we need to take this seriously. We might not personally have anyone at home, but the the possibility of getting the stroke is very easy. What are some of the statistics? But as we get to that, can you just give us a small, not sample really, but can you take us through what happens when one comes to you and, you know, you can see physically, but they also have given you the history of what kind of stroke they had? What happens? Is a report coming from him to you, to how does it work?
Thanks, Gary. Majority of my patients, of course, I get them from referrals, especially from neurologists like Dr. Ndege here. So after the patient now has gone through the critical care process, whereby now the clot is completely dissolved, then priority becomes rehabilitation. Then Dr. writes a note and gives a little bit of some history, medical history, and then, you know, he recommends for treatment. So when the patient comes to me now, it's my responsibility to take the patient through a whole assessment process, which may be a little bit of a medical aspect of it, a social aspect of it, and performance aspect of it. When I get the structures, the physical structures that has issues, then I make a treatment to try. For example, it's paralysis. I make treatment programs that will strengthen the muscles. If there are issues that also now have to do with performance of some few chores here and there, I try and associate. If there is some things that will require total changes, then I may need to prepare the patient for lifestyle change so that he can cope with the current situation. Yeah.
Wow.
Yeah.
Okay. Question. Is it possible to recover from stroke?
Yes and no. Now, like we said earlier, it depends on how massively you are affected. If you get a massive stroke, you know, sometimes you might even be in a coma for months and months. And so if a large chunk of your brain has been destroyed, then clearly you may not recover from that kind of thing. But on the other hand, yes, because some patients get very few symptoms. They get a very tiny area of damage. And there are patients who, within a very short time, they are back to normal, they are fully recovered, and they go back to their occupations, they go back to all their normal routines without any deficit at all. So really, the answer is that it depends on how much damage you have got. Most people do not recover fully. As from our case study, Mr. Edward, 7 years later, his arm cannot still go above the horizontal. So he has not yet recovered from his stroke. We hope he will recover, but we know that several people only recover to a particular level, and they are a bit functional, but not back to their former selves before. So the answer is that yes, some people are lucky and they may recover fully, but many others end up getting very, very severe damage and they do not recover from it.
You talked about medication, a lot of visits to you. Can you just give an overview of how that looks like, just for us to have a proper, what are these pills, what are the medications someone is on?
Yeah, now, you know, stroke affects, let's say most of the people may be elderly with various other coexisting conditions.
Okay.
And then even in terms of stroke management by itself, if you get a clot, you've got to be put on an antiplatelet medication, that's something like aspirin. You've got to be put on something for cholesterol, some lipid-lowering medication. Then you probably will be having hypertension, which may be difficult to control. So you might be on 3 different tablets for hypertension. You might be having diabetes, because that's often something people have. So you might be on 2 different medicines for diabetes. You might be an elderly man who has got something wrong with their prostate, so you might be on something for prostate. So many stroke patients tend to be on multiple numbers of pills. Yes.
Okay, Faith from Moloranga. Is this our first lady caller? Thank you, Faith. Good evening, Faith. Okay, Faith from Moranga, please try and call us back. You have about 5 minutes. We're about to wrap this one up to send in all your questions. Remember, you can text us live in studio on 22232. You can also call us on 0708 756396. That's 0708 756396. The number is running right below the screen. With us in studio is Dr. Kinoti Ndege, who's a neurologist, and Duncan Chengo, who's an occupational therapist. Let's just continue discussing on some of the things. You've talked about destroying people's houses. Someone came up with a nice plan. Kazi yako ni kubomoa.
Unajua, when you are discharged from home,
yeah.
Unfortunately, from the hospital.
Yes.
And unfortunately, when you are building the house that you are living in, you never contemplated one time that you can never ever be discharged on a wheelchair.
So is this advice you're giving to anyone who's looking to build a home?
Exactly. As a country, we need to move to that level whereby we put the people who are otherwise or differently abled into our planning structures. Yeah, if it's a road that you are building, it's important you make sure there is a road outside there where people can go with wheelchair, because there are people who don't walk. If you are building a house, it's always very important to make sure you minimize the number of stairs in the house, the least that you can, as much as possible. Whatever you are building, a kitchen, don't build all the kitchen, up here. It's always can have a reservation of another. Whenever you're building your toilets, make sure they are spacious enough. Yeah, etc.
Yeah. So be very considerate.
Very, very considerate. Yeah.
Okay.
Yeah.
As we do this, are there any things that you'd like to ask and appeal to the Ministry of Health in regards to stroke, in regards to this particular disorder, as we continue to get the questions on our call line 0708756396. I'm giving you free consultation with a neurologist and you're just sitting there. Call in, ask the questions you might have, and also with our occupational therapist with great training. We can start with you.
As I've told you again, in this country, we don't have a specific stroke rehabilitation center.
Except what you're trying to set up.
And except what I'm trying to set up with some few other people who thought like me, they're trying to put up their structures up. And it's important not to ignore people who acquire challenges in their process of, So
will you hold the thought?
Yes, please.
Please don't forget it. John in Roy, good evening.
Good evening to you.
Yes, sure. Go ahead.
Now, my question is, at times huwaga ninasikia kama sijui ni kwa damu, sijui ni kwa roho, sijui ni wapi. Good evening to you. Huwaga ninasikia ni kama ninashunwa mahali, ni kama kuna kitu kama tupini tunanidunga hivyo, nasikia kwa uchungu.
Wapi?
Hiyo inaweza kuwa inatokana na stroke ama
wapi? Unasikia uchungu wapi?
Ni kama kwa roho hivi, ni kama kwa blood stream, sielewi ni wapi haswa kuna kuwaga na kauchungu. Once in a while, kama wakati ninatembea hivi. Sasa nashindwa inatokanaga na stroke.
Daktari, do you have a follow-up question for him?
No. I think John has given us a very good illustration.
Oh, it's having a heartbreak.
Of just actually, John is giving us a very good illustration of just how sometimes difficult the process of diagnosing is.
That's true.
Because many patients will come with a description like what he has told you, and they will want you to diagnose them and tell them what it is. And those things are common. Feeling unadungwa hapa, feeling kitu inatembea kwa mwili inaenda upande huu. Pins and needles. Those things are common. Na ziko na many different causes. Zingine, they may even be some psychological things, but others may be caused by various issues to do with your nerves. Some neuropathies, neuralgias can present in that manner. So it's difficult, of course, to give a diagnosis straight away and tell John that this is what you have. But one thing I can tell him is this: that is not a stroke.
Okay, that's not
a stroke. Kama vile tulisema stroke ni kitu ambaye inakushika kwa ghafla. Ulikuwa sawa, then kwa ghafla unapatikana na hii weakness ama kitu ingine. So hawezi kuwa unadungwa every time na iwe kwa stroke.
Okay. Moses in Nakuru, good evening.
Good evening to you.
Yes, please go ahead and ask your question.
I'm Moses calling from Nakuru.
Yes, sir.
To appreciate the good work you're doing. May God bless you abundantly for informing us.
Thank you.
Thank you.
Okay.
Oh, that's so nice. You're hired. Call so every week. Okay, but you are holding a thought.
Yes.
Let's get back to that.
All of us, as we walk, as we live, we are candidates of acquiring some of these things. And it does not feel very good when one of us falls as a victim and you have to stay on, we call an acute setup of rehabilitation. You know that bed that every other person is admitted in, and rehabilitation is a long-term process. So I think, honestly, it will be important we look for structures, and we put systems in place, a place where every person can seek these services whenever such incident strikes.
Yeah,
yes.
It should be more accessible. We should have more information. Daktari has also been trying to share that awareness is trying to be pushed, and this is one of the places that you can, go ahead and talk to people, that anyone who's watching this show should be able to have this conversation with their children, with their family, and any other advice you have. Absolutely.
Now, as in regarding to what can be done in a coordinated fashion, by all the healthcare providers and the ministry, I think we need to have 4 approaches of looking at it. One of them is looking at the preventive aspect, because everything we have talked about so far is about what to do once the stroke has occurred.
Yes.
And everything we have talked about so far has brought out the message that stroke is not like a common cold, that you say or even like malaria, that you say you take medicine and after a week you'll be fine.
No.
Once you have one, that's the beginning of your problems. And those problems will be all the things you have described. So prevention is always the most important aspect of it.
Yes.
So if you look at the data from Western countries, the levels of stroke began to go down in the late 60s and 70s. Not because they had a lot of medicines and a lot of things, but because they brought forward lifestyle changes to their populations. They began to discourage people from smoking. They began to actively treat hypertension. They began to actively treat diabetes. And they began to limit the usage of salt in the diets of their people. So once that was discovered and that began, if you look at the curve, you find the numbers of stroke went down in the population. So that is the most important message that you can put across, that for any disease, prevention is always better than cure.
Yes.
So preventive management should not be forgotten. That should be one of the branches of management.
Okay.
The second branch is early intervention. Now, early intervention, the medication you have talked about, this Alteplase, which is available, is still quite expensive. And the ministry or the government can actually look into that, because still early management is better in the sense that if a person is going to have a major disability and you treat them on time, they will have a less significant disability. So it will not be expensive to maintain that person as it would have been if you had left them to have their full damage to be done. So early intervention is very critical. And that also involves even the authorities, even the county authorities, because transportation of people from their homes, ambulance services, road system to ensure that the traffic jams are things which are not so bad.
Yes.
All that kind of thing to make sure that early intervention works well for people. Then the second thing is going to be long-term support.
Long-term support.
Once you are finished with the prevention and early management, now long-term support is where people like Mr. Chengo come in, where all the rehabilitative services come in, everything that we have talked about. And also financial. Because you find lots of people, like, for example, what Mr. Edward told us, he was a teacher, but now he cannot be able to do his job. So people find themselves out of a job, and there are still people who have got a family to support and so on. So a system can be done where people who have got a disability, like on the clip we saw that Mr. Edward was still walking, he was still able to talk. So if he's a teacher and he can walk and talk, probably with a bit of assistance he can teach. Because to be a teacher doesn't mean that you don't have to limp.
That's true.
You can go to class limping.
Yeah.
So what we do is, for all these disabilities, people need to be encouraged to keep on with their occupation as much as possible.
And employers to be considerate.
Absolutely, because you find a lot of people being left to go, that now you have become a liability, we cannot keep you here. But these are people who still need some, who can still be productive members of the society. So long-term support, both in terms of the rehabilitative services, as well as making sure that people are still feel useful, that they can still earn a living and look after their families. That will go a long way in helping the whole thing of stroke and other disabilities.
Wow. Thank you very much. Those are great measures. Let's pick one last call, even as you get ready to answer how to feed a grandma who's suffering from mild stroke. Hello, this is...
Hello.
Yes, Hope TV. Who are we talking to?
Yeah, my name is Nyamongo from Kitale.
Thank you, sir.
Yeah, thank you very much. That's a wonderful discussion. Now, at times I feel like I am seeing trees moving.
Okay, so blood vision, is it?
And then I see like even houses. Like my eyes get blood, and then I'm not able to see what is going on, it's like, I mean, I want to faint, I want to fall. Has that anything to do with neurology?
Oh, yes, Mr. Nyamongo. Thank you for your question. That is highly likely to be something neurological. In fact, if you're somewhere in a stationary position and you feel like your environment is going around you, meaning that either the trees are moving or the house, the walls are moving, then that condition is called vertigo.
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 Okay.
And vertigo could mean that there's something wrong with your brain, or it might be something just in the ears. So that will need assessment. But then he feels like he's going to faint. He feels like he's a bit lightheaded. His vision feels blurred. You know, it can be anything, including even what you talked about, I think called a TIA.
Yes.
So it's important that once you find these symptoms and they're alarming, please, Mr. Nyamongo, don't stay with them at home.
Yes, please.
Early intervention might save you from progressing to something more serious. So make sure you see a health practitioner, a doctor, as early, as quickly as you can.
Okay, a question from John that came in is how to feed a grandma who is suffering from mild stroke.
It's important to note that people who get stroke are likely to develop challenges in swallowing. That's very important. And whenever you have a patient who has difficulties in swallowing, it's of utmost importance not to try, insist or force that person to swallow, because you can easily choke.
Okay.
So that's very important. So you may want to seek an opinion of an occupational therapist for an assessment of how much your GIT can contract and relax.
What's GIT?
Oh, sorry, your gut.
Okay.
Yeah, your gut. How much your systems
all
the way down they can control. You know, the
peristalsis.
Yes.
Nilisoma. Thanks, Dad. Thanks, Mom.
So, other than that, after assessing that, it's also positioning is very key. How you put someone who has a stroke to help the food, go down is also very important. And there are also factors to consider of what you feed the person in terms of whether the food is solid, if it's solid, how solid is solid, and what type of spoon you are using, other than the steel spoons made from steel. Spoons made from steel, they are not the best ones to use.
Yeah.
So you may want to make some few considerations here and there.
To plastic or?
To more plastic, shallow. We have specific spoons which are designed for disability friendliness when it comes to feeding. The last thing then, in eventuality where you have realized it's difficult to feed instead of risking, there are alternatives gastros can give for feeding and instead of risking. So I would advise him to seek an opinion. And then you'll be
It's like everyone has just woken up right now. All the questions are coming. Let's pick the last. This is the last call. Thank you so much for calling. Who are we talking to? Good evening.
I'm good.
Yes, what's your name?
My name is Purity.
Where are you?
I'm from Baringo.
Good. Go ahead. Kindly reduce the volume of your TV so that we can hear you better.
What's your name? My name is Purity.
Okay. When you call us, kindly reduce the volume of your TV so that we can get to hear you. Kibe is texting in saying, my pointing finger has been numb and I have taken the nerves medicine to no avail. What next?
Now, what is the diagnosis? That's the question.
Yeah, what is the diagnosis?
Why is the finger numb? Is it due to something local with the finger, or is there something? You know, there are a lot of medicines on the market called neuro this and neuro that.
Yeah.
Now, those neuro this and neuro that are often misused because the fact that they have neuro in part of their name, people think they treat all nerve diseases. And often what they may have is just some vitamins, maybe vitamin B1, B6, B12. And not every nerve disease is caused by lack of vitamins. So it's something which people need to know very, very keenly, that the fact that you have nerve medicine doesn't mean that nerve medicine is actually doing anything. You need to go through a process of diagnosis, that you are told that this finger is numb because there's damage here or damage there, and this damage has been caused by ABCD, and then you treat that damage itself.
Okay.
So routine use of neuromedicines, neuro this, neuro that, should be discouraged because sometimes they are often misused.
Allow me to put an input on that.
Sure.
I've experienced so many issues to do with hands recently, and I attribute this to to these
Oh
gadgets.
yes, you're always
These gadgets here and all the time, and your neck is always bent.
Okay.
So it's possible for you to cause some damage for the nerves that supplies the hand.
Are there some
from the neck.
exercises we can do?
Yes,
maybe?
there are plenty of them. You get that on a different
Not only you have to pay. Let's wrap this up. It's been so good talking to you, gentlemen. This has been a heavy conversation. First time I'm not home at 7. Yay! But just what are your final remarks as we wrap up the conversation on stroke, and what would you encourage each and every person that's watching us today?
Change of
You can look
lifestyle.
right there.
Change of lifestyle, very important to reduce strokes. So that is very important. Ignore sedentary life, too much smoking, too much drinking of alcohol. It's a risk for acquiring stroke. So be active, stay safe, eat healthy, live for longer.
Wow.
Yes.
Dr. Ari.
Yeah, thank you very much. Now, my final words are a reminder that people remember FAST. F-A-S-T.
Yes.
You might save a person from getting very severe disability just by the fact that you recognize that they were having a stroke and took them to hospital very, very quickly. So remember FAST. Then second thing is that stroke is a thing which can cause sudden unexpected disability, and it can happen to any person. So wherever you are, always have in mind people who have got various forms of disabilities. If you find a person who is visually impaired somewhere, think of how you can assist that person in terms of the environment, crossing the road. If you're in the process where you are a constructor or someone who is making something, even the pavements we have, are they good enough for people on wheelchairs? Are they good enough for people who are using crutches? Are people able to move around? You know, in other advanced cities, even the public transport, the buses are called kneeling buses.
Yeah.
Because they go down to the level of the street, and you can wheel your wheelchair on top. So those are things we need to think about, because it's a thing which can happen to any person. And if it happens to you, you just realize just how difficult life can be in an unprepared environment.
Thank you so much. You guys have been awesome. I think one thing I've noticed is your hearts are towards the people. Thank you very much. We've said prevention is better than cure. Get to know more, get to learn more. I would also like to encourage you, if you're watching us live, to share this video so that other people can get the information. Dr. Kinoti Ndege, the neurologist who we've had in studio, and Duncan Chengo, occupational therapist, have been spending time with us. Thank you so much. I wish you God's blessings as you pursue and you continue to serve people in various ways. Until next time, this has been Health Check, coming to you live from the nation's capital, Nairobi, on Hope TV, where you look and live. My name is Kerry Kagiri, and I need to get out of this mask. So let's go home. Let's go home.
Thank you very much.
Thank you so much for watching.